Next on Primary Care, stroke. Studies show Black Americans suffer strokes nearly 10 years earlier than other Americans.
Unfortunately, being in an underrepresented community or lack of access for medical screening, we're suffering silently until something happens.
Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care, the show dedicated to the care of African Americans. Any patient who has had a stroke is at higher risk of having a second one. African Americans are also experiencing strokes at younger ages and face greater challenges in recovery because of variations in post-stroke critical treatment. From experiencing the obvious fatigue associated with depression and rehabilitation issues, too many Black stroke survivors are not getting the appropriate care that they need. Here to tell us why not and more about this alarming statistic is Dr. Stephen Hardy. Dr. Hardy is a neurologist at Oakland Neurology Center and the stroke director at Henry Ford Rochester. Dr. Hardy, welcome to the show again. So glad to have you back.
Thank you for having me.
Good. We are still continuing to suffer from a lot of things that are just not being addressed, and in some areas are considered to be just the norm, and that's the way it is. Why are African Americans having this higher stroke risk in this country?
Well, I think it kind of dates back to those risk factors for stroke. So unfortunately, being in an underrepresented community or lack of access for medical screening, we're suffering silently until something happens. So we have these stroke risk factors of elevated blood pressure, high cholesterol, high blood sugar, sedentary lifestyles, not doing much physically, and with that accumulating in our systems, and then your body can withstand a lot, right, until something happens. So I think that's one of the main reasons why we're at a greater risk, and I think it is important to get that information out to address those things so we don't suffer as much.
It's the accumulation of straws concept, then that last straw breaks the camel's back.
Exactly.
So here again, what are the risks, not necessarily the risk factors, which we have harped on for a long time in this country. What are some of the early warning signs of stroke, or are there any?
Good question. So without screening per se, or we're at the house, we're not really checking. Well, I mean, if we were checking our blood pressure to see if it was elevated chronically, that could be a risk. But typically with stroke, there's no warning per se. It just happens abruptly when it happens, right? Sometimes people can have what we call TIAs, or transient ischemic attacks, where you can have one happen, goes away quickly, and then kind of crescendo within a 24-hour period. That may be the only possible warning sign, if you will. But typically, when you start having a symptom, you're having a stroke.
So what do we actually look for if there are no symptoms? You say we go back to addressing the things that we can make change on. I mean, like the blood pressure, like the lipid profile, like the lack of diet, exercise, like losing some weight. So, but as far as the brain is concerned, with this being the focal point of what happens when a person has a stroke, what is actually happening to the brain from an anatomical standpoint of view?
Yes. So when we have a stroke, I try to liken it to people having heart attacks, right? We'll just call it a brain attack, if you will. So you have the blood vessels that come off the heart that lead up into our brain, and they branch out in various areas and provide nutrients and blood supply. So what happens with a stroke, that blood supply is cut off, right? Especially with what we call an ischemic stroke, or lack of blood flow type stroke. So what that happens is it can be a blood clot that travels from somewhere else and gets lodged into the blood vessel. And then over time, if that area of the brain doesn't receive that blood, then it starts to die, basically. And then you have symptoms of the stroke. But also you can have a spasm or a pinching off of the blood vessel, or in terms of mainly like high blood pressure, smokers, diabetes, there's kind of a narrowing over time of the blood vessel, and it just narrows, and then it reaches a critical point where the blood's not getting through, and there you have the damage to the brain because of that.
Have you seen a difference in the development of stroke in patients who have high blood pressure versus diabetes? Is one more important than the other, or do they weigh equally?
Clinically speaking, I think they weigh pretty equally. Now, I would say probably maybe high blood pressure causes more strokes just because it's probably a little bit more prevalent, but I mean, diabetes isn't far behind for sure. And we always look at the type of stroke people can have. So typically the smaller strokes, which can still be very severe, come from those. And then another big risk factor is an abnormal heart rate, which can cause blood clots to go up. And those are usually the bigger ones that plug up those larger blood vessels and provide larger strokes.
Especially atrial fibrillation, which is underdiagnosed condition in our community.
Correct. Yeah.
Yep. So patients all the time want to say, "Oh, it's my stress." You know, if stress was something we could cut out, we would have cut it out a long time ago. But that's not the case. It is always related to some other element surrounding that patient. I have people complain all the time. It's my husband, it's my wife, it's my kids, it's my neighbor, it's my job, it's my boss. Well, I can't do anything about any of those factors. All we can do is to help people understand that they have to manage their stress the best way that they can, because it is a factor. Where do you put this in terms of not just being one of the things we check off on the boxes of list of things that we do, but how does stress play a role in the development of stroke?
I think stress plays a major factor in terms of, what decisions you're going to make from a day-to-day basis. So typically people who are even just mood instability in general, if you're depressed or anxious or just under a lot of stress because of work or family, you're going to make decisions because of that stress that are going to lead to having some of these risk factors accumulate and particularly cause some of, or be at higher risk for stroke. So, overall mental health, stresses can weigh in on you in terms of, your heart as well. Sure. So that can raise your blood pressure, that can cause your heart rate to raise. So typically in the moment of the stress, and if that happens over and over and over and over, you're just going to have that reach that straw that broke the camel's back, if you will.
Right. In the hospital setting, we've developed some acronyms. Everywhere you go, we try to help hospital staff and physicians talk about or include the recognition of stroke into their daily walks and what they do in the hospital. Tell us about the FAST approach, F-A-S-T.
Yeah, so kind of going back to getting out in the community and just telling people what these symptoms are, because early recognition, there are treatments that can happen if you can recognize a stroke pretty quickly. So FAST is an acronym that stands for face, arm, speech, and time, right? Okay. So what are we looking for? This is when you're looking at the patients. When you look at somebody, for the F, you look at somebody's face. Is one side of their face drooped or, not equal to the other? And then you look at the A. You look at their arm, is they're not moving one arm. You can lump the leg in there too, but they're not moving one side of their body like they're supposed to. If they're kind of moving one side and the other one's just not moving at all, that's a concern that someone could have a stroke, especially one side of the body. You always worry about a brain problem. Speech is someone slurring their speech, or actually in a contrast to that, are you talking to someone and they're unable to respond, or they're kind of it's difficult to get that word out, which we call aphasias, or they can't understand what you're saying. You talk to them and then they go off and do something else, or they just kind of mumble their speech. So those are signs of stroke as well. And then time is important, the T, because there are certain treatments we can give on an emergent basis that can, if you kind of, we talked about the blood clot causing the blood vessel to be clogged, we can break that up with a pretty good blood thinner in the emergency room to kind of dissipate the stroke symptoms as well.
So recently we had a very high-level, high-powered public official at a press conference all of a sudden began to have facial drooping and slurred speech. And after taking him away from the setting that he was in, it was reported to the public that this was not a stroke. And most trained professionals would have arrived at that diagnosis just by watching the press conference on television, that clearly what was happening, especially given the length of time that it occurred. This is something that we have downplayed to some degree in this country, because if people recover in a short amount of time from these symptoms, we tend to think that they're okay. And I've seen patients over the years that have, you can definitely say, yes, you were probably having a stroke. We weren't there at the time, but this has been reoccurring. This is something that we need to make sure that all the other risk factors, we address them, but at the same time, you need to have evaluation for a stroke. Why aren't we more aggressive as a community, a physician community, in addressing this? I mean, it seems like we just sort of like, well, we're glad you recovered and you're not paralyzed.
Right, yes, which is good. We're glad that people recover. But then we get into that secondary stroke prevention. So just because something happened for a few minutes and went away, I agree, it's nothing to shy away from or kind of throw to the wayside. So that could be a sign that's like a ticking time bomb, right? So if you had a small event, that can lead to a big event. So I think getting in and seeing your primary care physician or neurologist to kind of, okay, let's look and see, well, why did that happen, even though it was a short period of time? Let's look at your heart. Let's look at your blood pressure. Let's look at those blood vessels directly leading up to the brain. Are there anything that's going to increase our risk to have a big event? So the duration of the symptom, I agree, does not dictate what we do afterwards. We should treat it the same if someone had 5 minutes of symptoms versus 6 years of symptoms. We still want to prevent that next event.
You mentioned clot busters for patients that can get to services and treatment in a timely manner. Do we see any disparities in that area?
It again harkens back to just the access, right, and education. So if we're not aware of fast, no one's having those symptoms at all, then we won't know what to do, because we do need to do that within a 4.5 time window for those clot busting medications. So the disparity would be just lack of knowledge, and then access. Even sometimes in a rural community, we run into that. You can't get somewhere who actually has that medication available. So that would be the main hurdle with that lack of access.
So we should be overly concerned about closing down healthcare services and hospitals in overpopulated areas in this country, because access will go away totally for a significant number of people. This is another social issue that we have to deal with under this banner of stroke. Help us understand some of the disparities. We continuously come back to this point because they're continuously there, and until we do something about these things, they're probably not going to change very much. But what are some of the disparities that exist in stroke treatment? I think that most people sort of get protocol type standard treatment on the front end, but afterwards, thank God patients are surviving the stroke, but afterwards there's a whole barrage of services that have to be implemented, including things like physical therapy, for patients actually to continue to improve for months on end. What are some of the barriers that we're facing in that arena?
So I think the biggest barrier is post-stroke is cost. So I mean, these things that are needed are usually lifelong, right? Someone has a stroke at the age of 50 and they're living to their 80. Well, that's 30 years of services that are needed, depending on how severe it is. And then, depending on what insurance you have or what you may have to pay on top of that out of pocket for someone maybe to come to your house or help get you dressed or cleaned up, depending on the severity, or just with the strengthening exercises to try and get you back to where you need to be within those first year or so. That can be a big strain. So if you don't have access to that, I think that's where the disparity comes in post-stroke, and then these people oftentimes aren't doing what they need to do, speech therapy, so on and so forth. If it's not covered by the insurance or it's limited coverage, they don't get what they need to get.
We face this all the time on a primary care setting, because everybody wants the doctor to justify the use of these kind of services for the patient. Everything from, handrails in the bathroom, or a ramp that gets the patient access in and out of the house, or all of those kind of things, or any other kind of equipment they may or may not need. It can be very complicated in getting these kinds of services to a patient when everybody knows that they're needed. Nobody denies that these services aren't needed. I mean, they actually admit to, yes, we need it. So the problem is not whether or not the patient needs it, is how we actually get the patient to it. And you are right, cost is the rate limiting step, because as insurance changes on a constant basis, the cost changes also, and the ability for people to afford this is always an adjustment in what they're doing on a daily or monthly basis. So basically, do we have any other services after the doctors have done what we can do and the medications are on board? What other kind of services are available for patients in this arena?
Well, I think one, sometimes you can consult another physician, like a PM&R doctor, physical medicine and rehabilitation, to kind of help facilitate that process. But outside, speech therapy, physical therapy, we have some companies that specialize, and we often refer to them for home health care, and then some of them specialize in neural rehabilitation as well. So we may refer to those companies to try and concentrate on providing those services to get the access that they do need.
So we continue to preach to the patient population about lifestyle changes and how we actually control these parameters to lower the risk of stroke, but stroke still happens. What does the research show? Are we doing better? Are we reducing the incidence? Are we making a difference?
I think we are making a difference in terms of reducing some of those long-term disabilities that come from stroke, just by, like you mentioned fast earlier, just by the general public recognizing stroke, because we do have some things we can do to help reverse that in the acute setting when it's actually happening. So I think the incidence is still there. We try to do what we can do, but I think in terms of prevention, primary prevention of stroke, it's all about education and recognition of those signs so people can do well post-stroke as well.
Is there any value to some of the stuff that we're seeing in this TikTok environment? If you play this game every day, you can improve your memory in terms of dementia, or you can lessen your risk for stroke. Is there any value into brain exercises in a stroke patient?
Probably not directly, I don't think. I think it's always good just to have good mental health, and brain exercises are good in general. But let me take that back a little bit. If you're doing those exercises and it's a calming mechanism for your overall mental well-being, I think that we talked about stressors earlier as a risk factor. If it's more of a calming thing, then yeah, I think that could be of benefit. But then on the other side of the coin, if that's the only thing we're doing is looking at a screen and TikTok, and sometimes that's a little bit of a detriment to the brain as well. So there's got to be a good mixture between the two.
So basically we know that the social environment plays a role in this, because some of the worst cases that a primary care physician or caregiver has to deal with is a stroke patient who is now becoming depressed because of their condition. That's more of a social issue. Can involve some more types of medical treatment, but at the same time, it seems to be synergistic in terms of the disease burden that you're dealing with. And instead of adding 2 and 2 and getting 4, you're adding 2 and 2 and getting 5 with a patient like that, and that takes them to a different stage or a different phase in their whole treatment. How often are psychiatry type of services involved in the treatment of stroke patients?
So probably underutilized, I will say that. As the neurologist and obviously the primary care physician, sometimes there are things we can do in outreaching them to the psychiatry team if that does develop. There actually is a condition most people don't know about. It's called pseudobulbar affect, where it can happen in post-stroke patients where their emotional ability is just increases. So they may cry in a happy situation, they may laugh, inappropriately, or just seem sad or have these outbursts. And we think of that psychiatrically, but there is something specific we can use to help suppress that as well. But depending on the type of stroke you have as well, we see most of the depression and frustration in those strokes that affect your language. Because if you can't communicate and you're struggling to get your words out, even within the hospital stay itself acutely, that can have a pretty big detriment on the recovery process, because what do people do when they are depressed? They don't want to be as physically active, they're not interested in doing things, which can hinder their recovery.
We were talking a little bit earlier about how pain fits into this whole stroke picture. For the most part, probably not a associated symptom, but talk a little bit about how pain is and is not a factor.
So in terms of presenting with a stroke real time, typically it's not painful at all. The brain has actually no pain receptors. If you were to push on someone's brain, now obviously it's painful to get into that point, but the coverings of the brain and the skull, that's where all the pain receptors are. So if someone has a large stroke with a lot of swelling that's starting to push on other areas, because the skull is a fixed confined space, and you have this swelling and you're pushing on other things, then that's where people get headaches and vomiting and all these things because of that increased pressure. But in the brain itself, from a stroke, you don't get any pain. Now, after a stroke, you can have some pain. There's a certain syndrome where in a certain area of the brain where you can have pain related afterwards. Not a common thing we see, but if you talk about after stroke, when people have what we call spasticity, where they have tightness in their limbs and extremities, that can be painful to some people as well. And there are some treatment options, Botox or muscle relaxers, that can use to try to alleviate some of that tightness that we do see following a stroke.
So pain basically would be more geared toward or steered toward the post-stroke phase as opposed to an acute phase.
Correct. Yeah, I wouldn't. No one. Well, let me back up a little bit. So if someone has sometimes a bleeding type stroke, that can be a presentation of headache.
I've got pain right here.
Yeah. But again, that's more of, it's starting to swell and cause bleeding and pushing on other areas. So a bleeding type stroke, probably more so because of that factor.
Are there any new approaches on the rehab side to patients who have survived the stroke? Are we doing better in certain arenas as opposed to others? Do we have any new modalities that can be offered through the rehab services?
Yeah, I think the PM and our colleagues are making some strides for sure. There are some neuromodulating devices to try and help stimulate nerves in the recovery process, and then there's a new iteration of that annually. So I think they are making great strides in technology. I mean, it's gone a long way to try and help that recovery process for sure.
So basically here again, we're looking at a community that suffers disproportionately to this, probably because of a lot of other reasons that may or may not be addressed properly. Where can we as providers provide the shock value? Because to my mind, I think we are relaxing a little bit in this area to the degree that it's beginning to hurt us in terms of patient outcome. What can providers do to put this kind of discussion in the forefront of our communication with patients so that we can prevent stroke as opposed to waiting till the stroke happens?
Right. So I think with from a shock value standpoint, just kind of telling them the worst thing that could happen if we don't do what we need to do. So one of the common things, sleep apnea is becoming a big problem, right? So that can affect the heart, your blood pressure, and a big risk factor for stroke. And that can build up, and then you have the stroke later on because of that. So I think just kind of communicating that, like if you don't take care of this, this is going to happen.
Wear that mask anyway.
Right, exactly. It's irritating, but
Right.
not as irritating as being paralyzed on one side of your body. So I think adding that shock value, not to say we should necessarily scare everybody into doing things, but I think as long as they understand the depthness of what could happen, I think communicating that on our standpoint a little bit better would be good.
Are we looking at any new medications coming down the pike? We periodically see new products out there that actually kind of in a secondary environment in terms of how we prescribe and treat patients. Are there any things coming down the pipe from a scientific discovery standpoint of view that can say, if you take this, we can reduce the risk of stroke in the future, outside of just what we're doing now?
I haven't seen any big discoveries recently. It's mostly geared towards, what do we do if something is happening? There's been a lot of development of even the clot-busting medications, or sometimes going in and taking the clot out directly. So beforehand, I haven't seen anything too significant.
And the surgical approach, we touched a little bit on what intervention can take place when patients have particular issues that can lead to stroke.
Yeah, so we mentioned, time is brain, we always say. So the more you wait, the more damage can happen. So I always tell people, just go to the hospital no matter what if you see something off with that FAST acronym. But if you're within the 4.5 hour window, you can get the clot-busting medication. But up until 24 hours, we can actually do further testing in the hospital setting to actually visualize if there's a clot within one of those larger blood vessels leading up to the brain. And there's a procedure that can be done called a thrombectomy, where it's almost like a heart catheterization, but instead of going to the heart vessels, they go up into the internal carotid artery and go into the other vessels, and they can visualize it in take the clot out physically, and that'll restore blood flow to a large part of the brain. And we've had significant outcomes and reduced disability because of those procedures.
Carotid artery disease, in relation to that, we know that in a lot of instances it goes undiagnosed. But there are surgical and other techniques that can be used to treat that. Tell us about that.
Yeah, so I mean, there's certain screening that we should do just in general, just to look for carotid disease with an ultrasound. But typically, and if it's more than 70% blocked, there are a couple of procedures that can be done to get rid of that. Because you think of the carotid, that's the main blood vessel in the front part of your neck, feeding most of your brain. So if that gets, if that gets blocked or compromised, that can cause significant damage. So when we find that, you can do a procedure called a carotid endarterectomy, where they can actually surgically go into the blood vessel, clean out the clot, sew it back up. But then also they can go through the groin and do a stenting procedure, where they go up and then open up the blood vessel itself.
So we've got a lot of work to do in this stroke arena. Dr. Hardy, thank you again so much for joining us today. It's certainly been a pleasure.
Thank you. I appreciate you having me.
Our guest has been Dr. Stephen Hardy, stroke director at Henry Ford Rochester and neurologist at the Oakland Neurology Center. According to the CDC, nearly 800,000 Americans suffer a stroke each year. That may be a little low, but the good news is that managing risk factors like high blood pressure, diabetes, weight, and stress can lower your risk. If you haven't already partnered with your healthcare provider to begin taking charge of your health, it is time to do so. For Primary Care, I'm Dr. Lonnie Joe.